Good morning, good afternoon, good evening to everyone. My name is Vilma, and today we will talk about study designs that we used in implementation science. We will talk about the differences between traditional versus pragmatic trials as well, and we will introduce the concept of hybrid designs. So let's start with the logic, the general concept of implementation research. We all are aware that there are many interventions that are effective in clinical and controlled research settings, but we also know that there are proven interventions, many proven interventions, that are not implemented in the real world, in practice. So, in implementation science, we conduct research, implementation research, to study the best methods that allow us to contribute to bridge this gap in different circumstances and in different contexts. And one question which is very important is, what is the best study design to use in implementation research? There is not a unique answer here because it depends on several factors, but the most important factor is definitely the research question. Our challenge is to choose the best study design to answer the research question or questions that we have. Of course, there are other factors to take into account, such as the type of interventions we are working with, the target population, aspects of feasibility, logistics and settings. Costs are important, funding opportunities, stakeholders and their views on the topic of our research, the timeline that we have to comply with, ethical aspects, availability of data, and other factors. But again, the main guide for selecting the study design for our research is definitely our research question. And what type of study designs we use in implementation science? We use a lot of different types of designs. For example, we use qualitative research, which is very useful in context analysis to conduct these assessments. Participatory research is very important in implementation science as well. And of course, we use quantitative research, quantitative designs, and the combination of both, that is, mixed methods. In terms of quantitative designs, we can use experimental designs, for example, individual randomized controlled trials or cluster randomized controlled trials, where we don't randomize individuals or persons, but groups of people, such as schools or primary care clinics or hospitals, etc. There are specific types of trials as well, like step wedge, adaptive designs that are very innovative in implementation science as well, but in general these are the more frequently used in this field. We can also use quasi-experimental designs to test the effect of our interventions when we cannot randomize participants, patients, people, or clusters. So we can use, for example, before-after studies, time series analysis, etc. The difference between experimental and quasi-experimental designs is that the intervention, the assignment of the intervention is at random in experimental studies and is not at random but following other criteria in quasi-experimental ones. We can use also other types of designs like observational studies, case control studies, cross-sectional studies, prospective cohort studies can be very useful to better approach the different topics that we are interested in implementation science. We use also methodology related to health economics, for example, cost effectiveness or cost utility analysis, which are very important in terms of, for example, evaluation of sustainability of our intervention. And we also use existing databases. Either they have been created in previous studies or for surveillance purpose, for example. We also use individual data from, for example, electronic health records or other documents. So, we actually use a lot of different designs depending again on our research question. An important point that I like to highlight now is that when we talk about randomized controlled trials in implementation research, in general we refer to pragmatic trials. And what's the difference between, let's say, more traditional explanatory trials and more pragmatic trials? We can say that explanatory traditional trials seek to answer questions such as, can an intervention work under ideal controlled conditions? While pragmatic trials seek to answer questions such as, does an intervention work under usual, more real-life conditions? And here we can see some other important differences between traditional and pragmatic trials as well. For example, in terms of eligibility of the population, traditional/explanatory trials usually have more exclusion criteria, which contribute to the internal validity of the study but limit its external validity. On the other hand, pragmatic trials usually have few exclusion criteria, and because of that, higher external validity and generalizability of the results. In the same way, we can say that traditional trials usually include a limited, very restrictive range of individuals or providers or settings, while pragmatic trials include a wider range of participants, gaining again in generalizability of their findings. In the case of traditional trials, depending on the study, we can use active or placebo controls, while in pragmatic trials, usually we use active controls, such as usual care, for example, or enhanced usual care. In traditional trials, we measure clinical or even physiological outcomes to measure efficacy, while in pragmatic trials, we also measure clinical outcomes, of course, but are more focused on patient-centered outcomes and process measures that help us better understand how different interventions or strategies of implementation work. In general, in traditional trials, the follow-up is shorter and more intensive. In pragmatic trials, the follow-up period tends to be longer. For example, when our research question includes factors associated with sustainability and less intensive to make them more feasible with, again, working in real-life conditions. Traditional trials, as well, are often blinded. Let's think of pharmacological trials, for example, while pragmatic trials which more commonly involve non-pharmacological interventions, such as behavioral interventions or system interventions, are not blinded. Traditional trials are frequently randomized at the individual level. On the other hand, pragmatic trials can be randomized at the individual or cluster level. Cluster randomization is more common in these trials, these pragmatic trials, because they are frequently related to interventions at different levels, the individual level, the provider level, the system level, for example. Well, now I'd like to show you a couple of tools that we use to help us design our study. For example, PRECIS is a tool that allows us to evaluate different domains and so better understand how much more or less pragmatic our study is across these different domains that we have just mentioned. For example, eligibility, recruitment, setting, the setting where we work, etc. By using this tool, we are asked to rate each domain on a scale from 1 to 5, from more restrictive traditional approaches to broader, more pragmatic approaches. With this information, we can create graphs like this, for example. In this type of graph, the closer to the periphery we get across domains, the more pragmatic the trial is. On the contrary, the closer to the center the different domains are, the more explanatory, the more traditional the trial is. So this is one of these very useful, really, tools that we have to evaluate more traditional or more pragmatic trials. Finally, let's talk now about hybrid designs. What are hybrid designs? These designs are very specific of implementation research, and their main characteristic is that they combine both clinical effectiveness research and implementation research. According to the hierarchy of clinical effectiveness versus implementation in the study, we can distinguish 3 types of hybrid designs: type 1, 2, and 3. The 3 types of hybrid designs vary based basically on the amount of emphasis on effectiveness versus implementation outcomes. A type 1 hybrid is focused on primarily the clinical effectiveness outcomes of an intervention while exploring the implementability of the intervention. I mean, in this type of hybrid, we test the effectiveness of the intervention, that is, what are the clinical or prevention outcomes. That's the primary aim of the study. And at the same time, we explore barriers, facilitators, and we measure some process indicators. But the primary aim of the study is clinical effectiveness, clinical outcomes. Implementation outcomes are secondary aims, and we study them because we know that this information will be useful when we think of implementing the intervention in the real world. Very important, we use this type of hybrid when we need to generate evidence about clinical effectiveness. We don't have enough evidence yet about the effectiveness of the intervention, so we need to test that. And that's why this is the primary aim of the study. In type 3 hybrid, it is the inverse. We test uptake implementation strategies, often in a comparative way. That is, comparing different implementation strategies while measuring clinical outcomes at the same time and trying to understand those outcomes as a function of the adoption rate and fidelity, which are, as we will see, key implementation indicators or outcomes. In type 3 hybrid, then the primary outcomes are implementation outcomes, and clinical effectiveness is a secondary aim. Very important here, we use this type of design when we need to generate evidence about what is the best or what are the best implementation strategies. We already have enough evidence about the clinical effectiveness of the intervention. That is not our main problem. Finally, we have hybrid type 2 designs, which are in the middle. A type 2 hybrid has a dual focus on effectiveness and implementation outcomes. Both are equally important. Both are at the same level of hierarchy in the design. That's why we have co-primary aims here, effectiveness and implementation. In hybrid type 2, it is important to have not only a complete description of the intervention components, but also the implementation strategies that we will apply and how they will be evaluated. This is a clear distinction from a type 1 design. Another difference is that type 2 always need explicit measurement of implementation outcomes at the same level of importance of the clinical outcomes. For example, reach, adoption, fidelity. A hybrid type 2 is ideal when studying interventions that already have evidence of effectiveness in other settings or populations, but not in the current context or population where we will apply the intervention, for example. So we have uncertainty that there would be a similar clinical benefit and we need to measure that. For example, there may be data to support the effectiveness of an intervention in hospital settings, but not in primary care settings. That would be an example. So we have a lot of information, but we still need to know more about effectiveness in this new context. This design is also ideal when there is a momentum for implementation in terms of the system or policy demands. For example, sometimes healthcare systems directly go into implementing interventions with only preliminary effectiveness data because of government policy or the political context or any other reason. In these cases, hybrid type 2 provide an opportunity to capitalize on this momentum and study the intervention's effectiveness, plus, of course, how to successfully implement that intervention. As a summary, in hybrid type 2 designs, then the primary focus is on testing the clinical effectiveness of the intervention. The secondary focus is to explore implementation-related factors. This design could be a traditional effectiveness study, for example, plus a process evaluation. The primary aim is clinical effectiveness, the secondary aim, implementation outcomes. A hybrid type 1 is indicated when the evidence of the clinical effectiveness of the intervention remains limited. At the same time, while testing effectiveness, we take advantage of the opportunity to explore implementation issues and plan implementation strategies for the next stage. It's not enough by any means, but we can learn about potential implementation challenges from evaluating the delivery of the intervention during the trial. That's the logic. In hybrid type 3 design, the primary focus is on implementation outcomes. The secondary focus is to observe or gather information on the clinical outcomes. A hybrid type 3 is essentially an implementation trial plus an evaluation of patient clinical outcomes. The primary outcomes are implementation outcomes such as adoption, fidelity, and sustainability. For example, the primary outcome is implementation, the secondary outcome is clinical effectiveness. These type 3 designs often compare different implementation strategies. For example, clinics might be randomized to receive different sets of implementation strategies of or for an intervention, perhaps varying in terms of who deliver the intervention. Let's say, for example, nurses versus community health workers, or the intensity of the intervention, for example, frequency of text messages or the like. The secondary clinical outcomes are observed and are related to the level of adoption and fidelity produced by the different implementation strategies, which are again our main focus. Type 3 hybrid are indicated in several situations, but in all of them we already have enough evidence about the clinical effectiveness of the intervention. Our problem is definitely implementation. They are very useful, for example, to test scaling up strategies and adaptations needed to proven effective interventions. Finally, in hybrid type 2, there is a dual focus on the clinical outcomes and the implementation related factors. Both are equally important, both are at the same level of hierarchy, and both are co-primary aims. If we lay out the research pipeline from safety and efficacy studies at the first steps or stages in research up to more pragmatic effectiveness studies and then implementation research studies on dissemination, scaling up and scaling out, we can say that hybrid designs are placed here with components of both effectiveness and implementation. That's the main idea. Well, today then we have been through different study designs that we use in implementation science. We have reviewed the differences between traditional and pragmatic trials, and we introduced the topic of hybrid designs. I will be more than happy to discuss more with you about this topic in our coming plenary session. So thank you very much and see you soon.